what I'm going to do is let everybody kind of filter in. I'm going to see, we got lots of people jumping on. This is so exciting to see everybody. We'll give it about another 30 seconds or so. I see Dr. Perlman, all these awesome names. Yay! Thank you all so much for joining us this evening. So this is the, feel free, yes, to, yay, we're pumped too. Dr. Perlman, thanks so much for joining us. And I love it. So yeah, one of those first things is don't be afraid to chime in and use the chat. I know that there's going to be a lot of great conversation going on this evening, so definitely use that to make comments. If there's questions, we want to make sure that those get answered for you as well. So tonight for our SMSNA Advanced Practice Provider webinar series, we're talking all about partner health and kind of exploring what that means and how we can integrate that into our patients and looking at the couple too as a whole. So we are very excited to have some amazing professionals here with us tonight and panelists to talk all about the partner side of things. So let's go ahead and get started. So we'll do a couple of introductions here. Let me get my notes all out here. So we've got Kaylee Caswell and Mary Hitt. Both of them are going to be talking to us tonight, looking at, again, the partner role on it. So Kaylee is a women's health nurse practitioner at, is that Southern Illinois University? Okay. Yeah. I never know all of the acronyms and all this other stuff. So yeah, so she's a women's health nurse practitioner at Southern Illinois University Medicine's OBGYN division in Springfield, Illinois. She provides an all-inclusive trauma-informed gynecological care to adolescents and beyond. She's also an ASEC certified sexuality counselor, offering a specialty clinic for counseling and education to those born with female parts and pieces that are experiencing some sexual health concerns. Mary is a certified urology nurse practitioner, as well as a NAM certified menopause practitioner who's been working with men and women with pelvic floor disorders and sexual health concerns for the past 12 years. Her expertise includes non-surgical management of bladder and bowel incontinence, non-surgical management of pelvic organ prolapse, pelvic floor muscle rehabilitation and biofeedback, anorectal manometry, and the treatment of female sexual dysfunction. We also have tonight with us Chris Nelson. Chris is the Chief of Psychiatry Service and the attending psychologist at Memorial Sloan Kettering Cancer Center. So glad to have you on with us tonight, Chris. And then last but not least, we have the amazing Daniela Whitman. She is a clinical associate professor of urology at the University of Michigan. She is the associate editor of the Journal of Sexual Medicine. She is a certified sex therapist and a leading member of the Michigan Medicine Prostate Cancer Survivorship Program. Her research focuses on the development and testing of interventions that support couples in their sexual recovery after prostate cancer treatment. Just amazing group of panelists. I'm so excited to have you all tonight. This is, again, very exciting, and I'm just happy to get started. So first, though, I have been the ones that kind of have introduced everybody. I didn't tell you all this while we were chatting beforehand, but I wanted to go through. I always love to start these presentations and things like that off with a question, because I think it helps us to get to know you. So I don't even know if I should ask you this question, Kaylee, because I would say, if you could go anywhere in the world, where would you go and why? So Kaylee just got back from an amazing trip to Greece. So you took your trip of a lifetime. Was it awesome and amazing?
It was amazing. It was kid-free.
That's even better. Yes.
Right? Yeah.
Yes.
Yeah. No, it was amazing. We were on a boat for a week, island hopping, eating lots and lots of olives and feta and baklava.
Oh my goodness. Yes. Awesome. Well, Greece is definitely on my bucket list. Mary, what about you? If you could go anywhere in the world, where would you want to go and why?
You know, it's embarrassing to say it. I have never been to the Grand Canyon and the out west. I have a just turned 7 and a 10-year-old. So we were kind of waiting until they were a little older, but I married a super nerd Eagle Scout who has a PhD in statistics. And so it's on our list. COVID kind of changed plans, but we're hoping maybe next year for the following, we could do some camping and river rafting and check everything out. So
nice.
Not exotic, but
hey, listen, I've never been there either. So again, another one on my bucket list. Chris, how about you?
Anywhere in the world.
Anywhere in the world.
Listen, I think after the last year and a half, I don't care. Just anywhere in the world would be good, really.
Yeah.
You know, was that we actually just we're down in Curacao, which is an island in the South Caribbean. And my son, who's 16, and I, we got our certifications in scuba diving. And so I think what I do is I look for really good diving spots and I seek some of those out. So if anyone has any good suggestions for me.
Indonesia, where my in-laws go all the time. Indonesia.
Excellent. Okay. Indonesia. There it is. We're going to Indonesia.
Here we go.
Love it. Awesome. Thanks so much, Chris. What about you, Daniela?
So I have for many, many years wanted to go to India because I have read a lot about India in fiction, you know, novels written both by Indian writers and English writers. And I'd really like to go and see for myself. I think it's just a fascinating and beautiful culture. And of course, the food is out of this world, but I think it's a really beautiful country with so much variety in it. I would like to take a long trip to India.
Yes. Oh, yeah. Beautiful. India, I think, is on my list too. I definitely, New Zealand and Australia. That's kind of like a joint trip since they're so close together. That's on my bucket list when I have like 2 months to be able to escape, right? And just go and enjoy. So, well, I appreciate you all sharing that information about yourselves. It's always fun to know a little bit more about you, just besides what you do professionally. But I know our time is limited, so I want to make sure that we go ahead and get started. So to start us off tonight, we're going to talk about both kind of the whole topic for tonight's presentation is talking about erectile dysfunction as well as Peyronie's disease. But again, kind of exploring that partner role in it. So Kaylee and Mary, if you will go ahead and get us started and let's talk about that partner role.
Yeah. So Kaylee and I have the luxury, the pleasure of working together in the same practice. We are both within an OB-GYN practice in Springfield, Illinois. I came into women's health via exclusively working with male patients in men's health, andrology. And so I started off only seeing male patients and had an super awesome collaborating physician named Dr. Kohler. I was his first nurse practitioner and it was his first big kid job. So he was wonderful at, as soon as we kind of identified that no one in our region was addressing women's sexual health concerns, fostered education training across the country. So I now work in a women's health environment, but I do see some male patients sometimes. But I do want to say up front that because Kaylee and I work in women's health, a lot of the couples we may bring up in case studies or just in conversation, we work with a lot of male-female couples. And that's just kind of where we are. We're in central Illinois, not a huge urban environment, but it's kind of the patients we see. But we feel we want a lot of our information we share to be, it's probably applicable to any type of couple. So just to kind of be aware of that. Kaylee and I together, we focus on when we're dealing with female partners, we take the biopsychosocial approach to sexual medicine. So we put this up here on the slide. The slide's kind of busy, as Kaylee's husband mentioned. He was like, I think it's kind of busy, but just as a reminder that, men's health practitioners and having started in men's health, we sort of think more linear model for sexual response. And within women's health, we don't. So we see more of like a circular model. And so I put that up there kind of not knowing the audience. Was it more practitioners who see men's health only? But this is ways to kind of understand the female sexual response cycle and how it differs and how normalcy differs too. So within our practice, I am sort of the bio person. So I see a lot of the females who come in and have organic causes of dysfunction or want to rule out organic causes of dysfunction. That could mean hormonal issues. It could mean sexual pain issues, kind of working through that. 99 times out of 100, there's always the psychosocial component, probably more than that. And so Kaylee is sort of our psychosocial arm of women's sexual health. And together we try to, foster care and take care of any issues within the sexual response cycle that we are able to do so. As far as the biomedical approach and looking at couples that I've worked with men who have ED or Peyronie's, important points and kind of take home messages are partner engagement. So a lot of women don't know about erectile dysfunction the way we all do as providers. So they don't understand when their partner starts to have an issue. Their partner may not be transparent or open about disclosing the issue. So when we talk about seeking treatment, whether it's female treatment, male treatment, both, it takes two to tango, we always want partner engagement. So if a woman discloses to me, my husband, he's not been able to sustain his erection, and he's been embarrassed or he no longer wants to be with me, I will, within the female visit, talk about erectile dysfunction and its causes and kind of educate the patient right there, and always encourage that woman go to an office visit with her male partner to discuss the issue, discuss treatment options. So kind of partner engagement is sort of the thing, probably both of us, whether we're looking at organic or psychosocial issues, that we are focusing on the most. Oftentimes with my female patients, if there's hesitance or resistance from the male or lack of understanding, maybe one partner doesn't understand what I told the partner of the visit before, we want to bring the couple into the visit. So that can be with me. That can mean if the man has ED or Peyronie's, that when they go to the urology provider, we say, both of you go. It's always good to have a patient advocate, no matter what, for extra ears. This kind of, for patients who don't, we have a lot of training in this, all of us listening and on here, we're used to talking about these things, but patients are very nervous and they're very timid, and they want to know the answer, but they don't always maybe have the confidence or to ask. And so it's sort of, I feel like it's our job as providers to say, it's okay to ask these questions. These are, this is the disease process, that basic education, and then encouraging, hey, you go, be the extra ears. And then if you want to come back and talk about things, we can go from there. I think I'll kind of like turn to you and then I'll come back to some other things, but I think it's not encouraged always in a lot of practices for the partner to be in the room, but I think it's imperative for the couple to succeed through treatment, whichever route that might be. So the other thing is to kind of know is we're going to talk about this in terms of those couples who do want to seek medicine or surgical treatment of ED and Peyronie's. They look, or they might be very different than couples who don't, maybe the man develops erectile dysfunction for whatever cause, and they opt to remain sexually functional, but penile vaginal intercourse isn't the end game. So that's definitely a normal variant of sexual function that is often in urology, and I'm biased because I came from urology, not knowing a lot of the psychosocial, which I do now. And there's always this, we got to fix. And that's not the right answer for every couple. So that's where Kaylee and I together kind of work with couples and let them know what are all the options on the plate.
Yeah. So, I mean, knowledge is power. So when that partner, when the unaffected, I'm going to say kind of unaffected partner, I mean that very lovingly, comes in, when they, when an issue presents, they're very confused, they're anxious, is there someone else? Now I'm going to start to avoid, because I'm afraid to initiate and make my partner feel bad that that it's not working, or maybe I'm just going to, maybe it's me. So I'm just going to pull back and think that I'm broken. The unaffected partner is broken. What's wrong with me? Is there someone else? Like, let's get suspicious and when communication is, I want to kind of preface this too, is that some of this, we are assuming that the relationship is also healthy, right? There's so many relationships that there's poor communication. So in a relationship where there is communication, and that when the issue and the concerns are voiced, that's when a partner, can plan a talk and say, hey, something far away from the bedroom, when the context is good, hey, we have an issue, let's fix this. Knowledge is power. This is what I know about ED. This is what I know about Peyronie's. Your health and happiness is what's priority to me. And then, do you want to go see somebody, or would you like to talk about, maybe that's when sex counseling and sex therapy are there, because if you don't want medication or, to go down that route, then that's fine. That's fine with me. I'm okay with that. And that's not just a female partner, that is any, identity unaffected partner in this. I'm gonna quote Barry McCarthy, amazing. This is a brand new book. Sexuality is not an individual performance test. It's a couple experience of sharing pleasure. So sexuality is so much more than genitals and penetration and orgasm. It is pleasure and eroticism and playful touch and sensuality. And I think that is something that we miss in the conversations, because as medical providers, we see a problem, we want to fix a problem. We have 20 minutes, maybe, right? As APPs, we're awesome and able to have that amount of time. A lot of providers don't, so you have a short amount of time that allows, and that's not always, this part of it is not as comfortable to talk about, and it takes more time than that. So sometimes just planting the seed, hey, there's all sorts of options, medical and non, and I'd love to explore that for you, at any time, or we have those resources available for you to explore.
And I think, that's kind of why we like to use the biopsychosocial model, is to really offer patients, treatment seeking behaviors of both the patient. So if the man has AD and definitely is wants to fix the problem, we need to educate both partners and understand that the treatment seeking behaviors of the person affected, make sure that the partner knows that is his wishes, and then these are the options and what that means, and then what it in our case, because we work in female sexual medicine, what are her comfort levels with those treatments. I've worked with a lot of couples where you talk about ED treatment options, and I've had female patients say, absolutely no way is that vacuum device coming in the bedroom. Like, that is so not normal. I've had numerous women tell me, the penis feels cold when the vacuum erection device is used with the reconstriction band. So then we talk, with the couple and say, that's not the only option on the table. These are other options that you could go with. And
that's when having variable and flexible sexual experiences, where it's touch oriented, it's pleasure oriented, you can achieve orgasm or pleasure through, manual, oral, rubbing simulations. If a sexual experience doesn't go, according to plan or meet expectations, don't stop, don't give up. Sex is not a spectator sport. It requires your active involvement. Another Barry McCarthy quote, which is fantastic, but it's so true. It's so true. And I think we are, and I'm sure Chris, you can probably join in on this, like society, you know, we fall short a lot because when things don't work, we don't know what to do because we're not necessarily taught that.
And there's a lot of focus, I think, in men's health, like, you know, the linear model, like, and when we're talking about penile vaginal sex, which isn't the only kind of sex, but there's sort of this expectation that penile vaginal intercourse is the goal, and then it goes in this linear model. But once you explain to patients that that's not how it is, that's not how it has to be, that's not how it is for everyone. That's just a theory, really. So, you know, there are other ways to be intimate and sexual. And a lot of couples will opt to seek surgical or medical treatment, and that because they have a special kind of intimacy with penile vaginal intercourse. And those couples need to go the biomedical, you know, they need to follow that pathway. So, but I think educating partners about the disease processes is the foundation, and then kind of moving through what's normal, what's not normal. We don't have great sexual education in the United States. I don't know who's on here tonight, but I think that other countries might be better, maybe not. Media doesn't help, you know.
Yeah, knowledge is power.
Yeah, I mean, that's so true, right? And it's very rare, I think, a lot of times too, on the medical side of things, to ask, like, how is your partner functioning? Does your partner know that you're here today? What kind of conversations have you had around what you're coming in today, your ED or your pronase? What have you had with your partner? What kind of conversations? And so yeah, I think that's so important, yes, to bring that in. So, you know, for those of you listening, I think that's, I think the number one takeaway from what Kaylee and Mary are saying is, like, you know, how are you, you know, making sure that you're asking about the partner, right? We think about so much of what, you know, the patient is wanting or whatever else, but how are they going to be using, you know, now their genitals if they start working? Is this self pleasure, which is totally fine too? Is this partner, how's partner working? And, you know, so opening up that conversation. So now you know, this is a great way for us to kind of segue into the fact of, okay, now we've got the partner into this. We've talked to them a little bit about it, you know, thinking about now kind of the couple dynamic. And now, you know, we've got them into the room and we're having these conversations. What is this unit now as a couple with partner or partners, you know, within that relationship? So Chris, I'm gonna let you take over.
Yeah, great. Thank you. And thanks for having me on this webinar. It's nice to be here. It's nice to be here with APPs and present and talk about these things. And so absolutely, Mary. Yeah, it's great to be here. So thinking about the couple dynamic, really what I wanted to break it down into kind of, I think we need to, at least for me, it helps if I understand really the impact of ED and Peyronie's disease on men in terms psychologically, and then the impact on what that means to the partner, and then talk about that couple dynamic. And so thinking about ED and Peyronie's disease, the impact on the men, and the first thing and foremost is the amount of stress or distress and upset this can cause men. And so if you look at the literature, both for ED and PD, you know, depressive symptoms that would warrant evaluation, many studies have that around 40 to 50% of men with either ED or Peyronie's disease are scoring high enough on those depressive symptoms that they would warrant some type of evaluation. And so it really does impact them. And there's this sense for men that they're just not a man anymore. And so, you know, difficulty with erections, if their penis is bent or they describe it as broken from Peyronie's disease, there's this sense that they're just deformed, right? And they're not a man anymore. And especially things like erections goes at the core of what it is to be a man. And in one of my focus groups that I ran, like a man described sexuality and actually erections, specifically erections, as the ground he walked on since he was a teenager, right? And think about the concept of what that means for men, right? And exactly right, right. And like, you know, kind of my best example is that, you know, one of the patients that that I've seen. So I'm at Sloan Kettering Cancer Center. I work with cancer patients, and I was seeing a man who had prostate cancer and had a radical prostatectomy, and so had difficulty with erections. And but this was a man who served in the military, and what he did for the military is he jumped out of planes basically, and he jumped out of planes like after the equipment went out. So like if they're pushing jeeps out of plane, or if they're putting munitions out of plane, he would jump out after it, and he would be responsible for disconnecting everything and getting the jeep running or something like that. And he talked about how like if it wasn't anything that wasn't bolted down went off the plane, and he'd jump after it, and he'd jump out of any plane anywhere. And so like you know, for his service, he now has spinal stenosis and he needs knee replacement surgeries. Physically, he's really, and when I go like in the waiting room and I, you know, greet him, he's like, hey, you know, hey, give me a hand. I need a hand up off this chair, right? And you get him up and then, you know, when I first met him, he talked about how, you know, he had surgery and his prostate cancer is back. He was micrometastatic, and so he's moving on to radiation. And so it's a stressful time for him. And all of this, all his physical problems, what he talked about, what upset him the most was the difficulty with erections, right? And so it impacts men greatly, and men believe their partner will leave them because of this. And so just think of that mind frame, right? Think of that perspective of men. And then, you know, there's the notion of the male perception of sex. And I think Kaylee and Mary were really talking about this. And so, you know, for men, sex is an erection, it's penetration. And you know, in general, that's the perception. And so for a man, like difficulty with erections means that they're not having sex and they can't perform. And so they approach from that perspective. So that's what's happening, a little tidbit of what's happening with men in the perception. And then so the impact of ED and PD on the female partner are really on the partner. You know, whether heterosexual or gay, many of these concepts still hold. But it definitely increases anxiety in sexual situations. And Kaylee and Mary kind of touched on this a little bit, not really sure kind of what's happening. Does the partner ask? And then, you know, what can happen with the partner, of course, is can pull back, because if it's in a sexual situation and a man has difficulty with erections or their Peyronie's disease and he quote unquote can't perform, he becomes distressed. The partner obviously senses that, feels that partner becomes distressed, and then it becomes a really distressing situation that was once fun, was interesting, something that they looked forward to, now is something that is stress inducing. And you can imagine then a partner pulling back, saying in the bedroom, you know, I'm not going to push, I'm not going to ask, I'm not going to push, I'm not going to question, because I feel the distress. And so that's for the partner. And then also really like a significant impact on the partner is if a man has ED or PD, they may actually be withdrawing from all intimate contact. And so not necessarily only the contact in the bedroom, right? But that intimacy outside the bedroom. And listen, if I had, I guess the expression is if I had a nickel for every time I heard this phrase, that's the expression. But, you know, for inflation, can we say, can I have if I have $5, like every time I heard this, right? Which is, you know, a man says, what's the use of getting anything started because I can't finish? And so what does that mean outside of the bedroom? What potentially means is a man's with, oh, go ahead, Mary. Yeah, go ahead.
I just want to interject because having grown, like I said, grown up in that field, I now hear the female partners, and what they say is like, my husband, he used to touch the small of my back in the kitchen or kiss me goodbye or hold my hand when we were out. And I miss that. And so, you know, that woman in that moment, she's cooking dinner or he's cooking dinner and just wants like a little bit of non-sexual intimacy, but just closeness. And this is so true with ED and PD, that just normal couple interactions go away. And then that has really profound impacts on the relationship that are not outside the bedroom. Yeah.
Excellent. I couldn't have said it better myself, Mary. That was excellent. So were the partners, where the anger and the frustration for partners tends to really build up, is like there's some disappointment about loss of intimacy in the bedroom, but from my experience, this is clinically where it really builds up is that intimacy outside the bedroom. And that's where couples are in seeing me, and the female partner or the partner is saying, I'm at my end of the rope. I agreed to come here to talk with you about us, but this is it, right? I'm going to leave if he doesn't start recognizing me in those moments that Mary had talked about. And so, and then for heterosexual couples, the female perception of sex is more of that intimate sense. And Mary and Kaylee were talking about this, right? Opening up the repertoire of what sexual interaction is. And I'm using generalizations here, I understand, right? But in general, females, right, are potentially more interested in things like the closeness, the intimacy, the togetherness, the exploring those types of things. And if you kind of look at the literature in couples interventions, those couple of interventions that focus more on how to get a man's erection back, men tend to score better and highly kind of rated in those interventions. Those interventions that focus more intimacy, the female partner tends to score higher. And so kind of combining those is important. But what happens then is it tends to be a disconnect about how they're thinking and how they're feeling about the situation. And my phrase is he said, she said, or he said, partner said. And it has to do with the dialogue where a man says, I'm really upset, I'm really distressed about this. And the partner says, trying to be supportive, it's okay, I'm concerned about you, I'm concerned about us as a couple, and your erections are not so important to me. And then a man says, what do you mean my erections are not so important to you? A female partner tends just not to really understand this concept of how deeply embedded kind of erections are for men. And that starts the conversation and the interaction off on this conflict and this anxiety that builds up. And so, yeah, Mary, go ahead. Are you?
You're just totally feeding into, like, I deal with this all the time. So, and this is like the least clinical or least evidence-based thing I'll probably say all night, but having worked with men first, I just tell the females when they start to talk about encounters that you're describing, I don't know how to say it better, but I say for many men, their penis and its ability to become erect, it's their pride stick. That's how it's always worked. It's worked in the night when they were sleeping since they were little kids. It's when they want it to work, it works. And when it stops working, it's something we can't understand in the same way. But, the most simple way I say it's like, it's their pride, it's their who they are. And we need to respect that. So again, this is not evidence-based. This is my simple way of helping a woman understand the impact of these diseases on men.
Yeah, and that's great. And absolutely. And it's that understanding and that disconnect. And the female partner is really trying to be supportive, saying, it's okay, I'm not all that concerned. And it comes from a really good place, but the man just has difficulty hearing it. And so for APPs, some things that like in terms of working with couples and even educating and talking about this, Kaylee and Mary are talking about how to do that and in really good examples with the couple, and really talking about with the couple the impact on the man and how the man feels, and kind of how the female partner might take that. Facilitating discussion, and then refer to a psychologist or couples therapist. And it's really so when do you do that? Like when you're facilitating that conversation and that discussion, if the communication doesn't seem to be there between the couples, and you can kind of, when you're with couples, really kind of see couples that tend to communicate fairly well and have skills to do that, and other couples where it's just not there. It's those couples that have difficulty communication, the skills might not be there. That's good then to refer to a psychologist and a couples therapist. And so I think I'll stop there because I know Danielle is going to talk more about kind of that notion of potentially working with couples. And so I'll stop there, and thank you for having me.
Yeah, awesome, Chris. And I think that's where I think what we're seeing right now through the pandemic is a lot of therapists are full, they're booked, right? And so, I think one of the things that for us to take away from this also in that APP role is the sex counselor, right? And that's kind of what Kaylee, was really doing, is there's so much that you can do as a medical provider, adding a little bit of that counseling to it. If it's a simple just education and just, again, how can you, again, like you said, facilitate that discussion and bring in that partner to have more of that well-rounded conversation. I think a lot of things can be talked about and discussed within that medical appointment. And then again, like you said, if we're struggling to go on beyond that with communication, or other types of relationship discords, that again, a referral to a couples therapist can be really, and a psychologist can be really, really helpful. So awesome. Thank you so much. And Mary, this was what I wanted. I wanted this, again, like I said, robust discussion. So, well, I know we definitely want to move on to kind of the sexual health and cancer, and not just looking at necessarily the dynamic of the couple, but now kind of together again as that couple role. So Daniela, take the floor. Oh, and you are muted, if you could. Yeah.
I also want to thank Alice and the APP group for inviting me to participate in this panel. This is so much fun. This discussion touches on so many things that all of us work with every day. And everything that you have said, of course, is completely relevant for cancer patients, because essentially anybody who comes to a sex therapist, which I am one of, is dealing with a loss. Is dealing with something that's not working. And while people often think, oh, sex therapist, that must be just fun and games and sex toys, and there is some of that for sure, but this comes at a later stage. The first stage is recognizing that there's been a change, there's been a loss, usually a loss of function, and somebody's very upset about it. And of course, if somebody's loses a function because of cancer or any other reason, the implication for the partner is that they may not have experienced any loss of their own function, but their sex life might be unalterably changed as a result of that. So everybody's facing loss. And I am, as a social worker, I'm very interested in process. How do people get from experiencing this loss to feeling like they might be able to have a sex life anyway? How do they get from that A to B? And really throughout my work with cancer patients, I've come to understand how important addressing loss and grief and mourning is in this context. And this is something that is true for the patient for sure, because it's very obvious what they've lost. It's a little bit less obvious for the partner, particularly because partners are often not addressed. And so nobody really asks the partner, what is their loss in this situation and how do they feel about it? And so those losses have to be addressed. And, when Chris and Mary were talking about the couple and how there is this disconnect between the men feeling this deep grief about loss of function and the partner, female partner in this case, because it's not true in same-sex couples. The female partner is reassuring and feels like, why is he so upset? We did a focus group with partners of men with prostate cancer, and they specifically wanted to understand, what is this about men's deep grief about their erections? And we have to think of it not as of the penis and its function, not just as a sexual organ. We have to think about it as a part of the man's body image. Kind of what Mary was saying about, men live with an erection from the time they're quite small. It's like losing something that's just a part of you. So it's not just the sex. And partners have to understand that the man has to grieve something on his own, that they can't just help him out of it, and that they have to respect the man's grief and that it's okay for him to do it. At the same time, there's another loss that the partners experience that I only learned when I began to work in prostate cancer, which is partners, male and female, experience an erection in a partner as a sign that the partner is attracted to them. And now if there is not an erection, or if there's inability to have intercourse because of peyronie's or for whatever reason the penis doesn't function, the partner becomes distressed because now the partner doesn't know how to interpret or what kind of signals he or she's going to have. And that gets to communication. I think we all believe that communication is essential. In our research, we found that for many couples, sex is perfectly good and nonverbal for decades. People have all kinds of ways of signaling to each other that they're enjoying their sexual relationship, never discussing anything, never using the words, and just emotionally reacting. And when a couple is dealing with a dysfunction due to cancer or any other condition, they have to start to talk. And people don't always have the skill. And I think when we're encouraging people to communicate, we have to assess whether they can actually do it. I saw a couple just today who have a complete lack of understanding what's important to each other in their sexual expression. They've never talked about it, but it was fine until the cancer came. And now they have to talk about it and they don't really know how to do it. So I think it's very important for that to happen. And the other aspect of communication is, we're always supporting the affected person. We always support the person who's got the sexual dysfunction. And then, we certainly give room to the partner. But one of the things that I have discovered in some research that I did on partners was that when I asked the patient and the partner about how they understand the other person's emotional and support and sexual needs in the context of this distressing situation, the patient had no idea about the partner. They had no idea. They thought the partner might be distressed and needed support, but they never thought about what the distress was and what sexual needs the partner might have, other than the anxiety, driven fear that their erections were going to not satisfy them. But sex relies on mutuality. Good sex relies on mutuality. Good sex relies on people being able to know what each other needs and trying to meet that. And in the cancer context, it also relies on expanding the repertoire, as Kaylee and Mary were talking about, where people have to learn to experiment a little bit. And so we're not trying to teach men to be women and just be emotional, right? And we don't try to teach women to just attend to erections. And in some same-sex couples, this may mean that the typical way that they've interacted, particularly if they have penetrative sex, is very altered. If a man had radiation and can't have insertion into his anus, or the man had prostate cancer treatment, has soft erections and now can't penetrate. All these things become important. And I have had gay men say to me, why didn't anybody talk to me about other ways of stimulating for sexual pleasure? Why is everybody always talking to me about erections? So it has to be done in a sensitive way so that we don't discount the importance of erections. And we have to understand each patient's goals and then also realistic expectations for what they might be able to get. So working through these emotional or practical challenges, in a biopsychosocial context can be very challenging, but it can be also very satisfying, because couples who learn to talk, who learn to grieve together, who engage in sexual activity, even though they may not be thrilled about using sexual aids, end up sometimes saying they feel closer. They feel like they have better, more satisfying sex because they are more emotionally intimate during their sexual expression. And that is an outcome that, from my point of view, who loves to understand the process, excellent. Because people are having good sex in spite of sexual dysfunction because they went through the process of grief and mourning, mastered it, and come to terms with what their sex life is going to be like going forward. Thanks.
Yeah, and Danielle, I have so many questions. I know, because again, we're talking about grief and loss, and again, we're so focused on, again, penis and vagina, intercourse. And one of the things that I talk to a lot of my patients and partners and couples about, right, is that we should look at sexual activities as what are the seats at a table. Right. We have so much of this hierarchy of what is better than the other thing. And penis and vagina intercourse seems to be at the top of that ladder. But rather looking at a table and what are the things there at our table that we can use, to be able to engage in intimacy. And that sometimes just even naming, like, what, penis and vagina intercourse is in timeout right now. They are not allowed at the table. Right. Listen, I got little kids. We have timeout all the time. So, it's they're just over here for right now. It's not that they're out of the room and out of the house and gone forever. It's just they're sitting over here for right now. And so again, kind of looking at it that way, and then looking at the positive side of things. What are all the things that we're gaining, from this? We've been so focused on penis and vagina intercourse, but now we get to gain kind of the closest of mutual masturbation or oral play, or again, those sexual aids we can bring into the bedroom or into the relationship. One of the questions that I had for you that I would love for all of our audience members to maybe take away is, we talk about communication. What is a really just simple, basic communication exercise that you can give to that couple to start them communicating? Do you have one that you really like to use?
I'm not a person who uses exercises. In talking with couples about communication, I think I try to get them to communicate in front of me, quite honestly, about what it is that they are thinking about. Oh, well, I can tell you one thing easily, actually, though I don't think of it as an exercise, but I think maybe it is one, Alice. Oftentimes, as people start making love after they've experienced the dysfunction, what they do is what somebody described earlier on. They start sort of thinking, oh, this is not going to be that good. I'm really anxious about how this is going to turn out. My partner's not going to like it. Am I even going to achieve orgasm? Right? So all the good dopamine and testosterone that are helping the arousal are just going downhill, right? Because now we are starting to feel anxious and depressed. So I always tell couples, if you start having these feelings interrupt what you're doing, tell your partner what you're feeling. You, partner, do some comforting and tell what you're feeling. Everything is acceptable because you're going through the grief process. Educating people about the grief process is huge because it really takes away the guilt about feeling feelings that are not positive.
Right.
And so teaching people about grief and teaching them to interrupt sexual activity when they're not feeling good, reassuring each other, and then going back to it, not giving up, going back to it. Either in that moment or maybe when they feel a little bit better, by knowing that this is grief and that they're supposed to be able to tell each other and nurture each other when they're feeling it. Okay, that's an exercise.
Not a pass-fail test.
No.
Right?
No. And I think when I first met Danielle a little bit ago, earlier the week, I'm a nurse practitioner, but grief and mourning are a part of a lot of disease processes. But I think talking with couples about optimizing sexual function with these organic barriers, moving from grief and mourning to the word healing can be very empowering for the couple to just, to say, grief and mourning are so imperative part of the process, but the end game is healing, and healing it's individualized, just like care, and it looks different for every couple. And all your points, Daniela, on communication were just spot on. And getting couples to talk, thinking about providers, and those of us in the sexual medicine community are really anomalies. We're comfortable talking about this, but a lot of the providers, whether it's primary care, whether it's cancer doctors, radiation teams, like people in our society are just not comfortable talking about sexuality and sexual function. And so I think there's probably a lot of encounters these patients, we don't even know that they've dealt with over the years when they try to bring up the problem. But basic communication from the healthcare world, they're probably so amazingly relieved to meet Chris and Daniela, and to have this very safe environment to talk about that. But I think we do need to know and think about that these patients have probably been through what might be called medical trauma, trying to bring up issues if they're brave enough to do so. The only other comment I had about Danielle is that I wanted to bring up, because I found it helpful for male partners of female patients, is that we need to remember, depending on the research studies you look at, and they're pretty good studies, only about 30 to 40% of women are able to orgasm with penile vaginal sex. And so as part of that healing process, education, just like Kaylee has said, education is power. It really is an understanding. When Daniela talks about oh, what is going on with my partner? That's a very simple fact that a lot of male partners don't even know. There could be covering or, peeking it kind of things, but learning that and understanding that can all be part of the grief and mourning and then into healing process.
So can I just add to that? You had that model, that Vasson model on your slide, which is something that's very helpful in considering when people can't have as spontaneous a sex as hormones will drive them to, particularly postmenopausal women, and then people who have to use sexual aids. The idea of starting from a neutral position. And so first of all, many men don't understand that menopause makes women lose desire because of loss of estrogen, not because they don't care about it psychologically. Women often don't understand that about themselves either. And women often mourn the loss of their own desire as well without really fully understanding. So education, I think, is huge for both men and women. And the idea for men in the same-sex relationship or heterosexual relationship that's important, I think, is understanding that you can go to a sexually pleasurable encounter from a neutral position, that you can start just knowing that you want to be intimate, and that stimulation is going to stimulate desire and arousal simultaneously, that you don't have to have this like hot feelings that people just miss and wish that they could have. And so that's I think is a very important model to also teach people who are dealing with these situations that it's okay to start from a neutral position.
And it's normal. It's a variant of normal sexual female function. So, yeah, exactly. Letting the patient know that. Yeah.
Well, I know that we are getting, it's been an hour already. Goodness gracious. It just, time flies so fast when you're having just, again, these just very rich conversations. And I know all four of us, five of us could definitely sit here and talk about this for the next like 6 months. And so there's actually not any questions, but what I would like to do kind of at this time is we'll kind of go through each of you all. And again, if there is just one takeaway, one thing that you want to challenge the audience to start implementing tomorrow, what would it be? Kaylee, how about start with you?
Yeah, so I've learned, Elise, you've seen me through this journey. Elise was my supervisor, my ASEC supervisor, amazing. You've seen me through this journey, but like having that counseling piece now within my practice has helped me immensely, because now I can I can put together not just the whys, but the hows and what to do. Like I tell my patients, I said, we're not going to just talk about it, we're going to do something about it, so so a little bit of that, definitely that biopsychosocial component in it, involving the partner. Knowledge is power. That's always kind of my motto. Knowledge is power.
I'm gonna get you a bumper sticker that says
I know. I say it all the time. You're probably tired of hearing this, but and just really like having to really reteach people, because we have not done a good job in our society that it's pleasure, and not it's pleasure oriented, not penis and vagina and orgasm oriented. And that's a hard concept to really get people to travel down, and showing them how they can do that, so involving that psychosocial component, I think is just, it's awesome. It's so much fun too, because then you you go down the rabbit hole and it's just amazing.
Exactly. Mary, what about you? What's that one thing you want people to know or start to implement tomorrow?
Yeah, so I think one of the most important things I learned, and I actually learned it when I started in male infertility, it takes the stress off, it takes the pressure off. Every time I see a female patient who comes in, maybe sexual pain, low sex drive, I immediately, I say, why are you here? I'm eager to talk. But one of the very first things I start to encounter with is, tell me about your partner. Do they have any sexual dysfunction? Do they have any sexual health problems? And I'll even name them. Like, these are some examples I've heard, normalizing it. And I think for APPs treating men, ask about the female, because it takes two to tango, and or the male partner too. But we're coming from what we're talking about, there's probably something going on, and that might be the first time that man thinks about the partner in that way. And that has just changed my practice, where it's easier to engage the couple by, it almost takes the pressure off. The person's so nervous to see you and talk about this, that when you open it, talking about the other part of the couple, they're relieved. So
yeah, exactly. Awesome. Thanks, Mary. Chris.
I guess in my main takeaway is just understanding that the partners may be talking on different levels. Just, and they just might not be understanding each other around these concepts, and just be aware of that.
Yeah. Gotcha. Almost kind of playing like mediator, right? Getting kind of both sides of the stories and bringing people, back to kind of, again, that kind of neutral ground that kind of Daniela was talking about too. So yeah. What about you, Daniela?
Well, I think I'm going to suggest that anybody can ask the following 1 or 2 questions. Even if they don't feel particularly comfortable with the topic. I mean, everybody's here in the audience is interested in sexual medicine, so it's probably a comfort level here pretty good. But this is something that you can really spread around to your oncology and other providers around you, which is to say, any patient can be asked, do you have any concerns about how you function sexually? And do you have any concerns about your sex life? Because the sex life means a partner or lack of partner, that kind of thing. And then if they say yes, then you can just say, would you like to have help for these problems? And then I think it behooves any medical professional to find some sexual medicine, sexual health providers in their area, so that they can have that person in their back pocket and can offer that referral, so that they don't have to feel the pressure to offer all the solution themselves. This is something that sometimes prevents providers from even asking the question, because they feel like then they're going to be responsible for the answer. So I know that in my hospital, I have some colleagues who will say, oh, ask that question. And when the patient says yes, they will say, I have a colleague who has an expertise in this, and I'd like to refer you. Then the patients don't feel like you're somehow dumping them because you don't want to help them. They really feel like you're taking care of them because you have a colleague who can help them. So that would be my takeaway. Just ask.
I love it. Well, this has been wonderful. And I always learn so much from you all and take away just so much vital knowledge. So again, appreciate you all being here tonight. This was just fantastic. And just want to remind everybody that we have our annual fall scientific meeting coming up in Scottsdale, Arizona. And gosh, just like 3 weeks. So thank you all so much for being with us this evening. And I know that if you have any other questions, you can definitely reach out to us, reach out to SMSNA, and they can get you our contact information. Thank you all so much. Everybody have a wonderful evening.
Thank you.
Thanks.
Thank you.
Thank you very much for inviting us. Bye-bye.
Oh, absolutely.